Friends, welcome to this second part of the nutritional anemia class. In first class, we have discussed about the nutritional anemia which was caused by iron deficiency. In this class, we will discuss about nutritional anemia which is caused by the deficiency of folic acid and deficiency of vitamin B12. These anemia caused by the deficiency of B12 and folic acid are known as megaloblastic anemia. Today we will discuss this type of anemia in very short brief lecture. I request you all who have not yet subscribed to my channel, kindly subscribe to my channel. In introduction, we can say that megaloblastic anemia is characterized by the presence of macrocytes in blood. The MCV of RBC is increased in this type of anemia. The cell size will be more than 100 or 110 falcoliter, and the megaloblasts are present in bone marrow. This type of anemia is mostly caused by nutritional deficiency of B12 as well as folate, or there may be defects in their metabolites. Sometimes there may not be a dietary deficiency of B12 or folate, but the deficiency may be caused by defects in their metabolism. Usually, the deficiency of these both B12 as well as folate is clinically and hematologically indistinguishable. We are not very well able to distinguish them hematologically as well as clinically. That's why the single name megaloblastic anemia is designated to both the entities caused by either deficiency of B12 or deficiency of folic acid or their combined deficiency. Some other deficiency may also cause megaloblastic anemia, or they may be related to megaloblastic anemia, and these deficiencies are of vitamin that is thiamine, ascorbic acid, as well as vitamin E, that is tocopherol. Infancy and young children, vitamin B12 deficiency is now coming to be more common. Usually, previously it was not very common. Pernicious anemia, a category of hereditary anemia caused by the deficiency of intrinsic factor due to autoimmunity, is not a disease of infants or young children, which is the most common cause of B12 deficiency. But now infancy and young children also have B12 deficiency, and the most common cause is maternal deficiency and deficient breast milk in B12. Most of the cases occur in vegetarian families because B12 is usually found in animal source, animal products, and families which are strictly vegetarian usually suffer B12 deficiency. If we talk about epidemiology, then the most commonly affected regions are tropics and subtropical areas, including our area, that is South Asia. The commonest age group which suffer with B12 deficiency or folic acid deficiency is 3 to 18 months age group, that is infants as well as early toddlers. It is usually associated with prolonged breastfeeding and material deficiency. Prolonged breastfeeding by a mother who is herself deficient in folic acid or B12, that may result in this type of anemia. Supplementation of folate during antenatal care to prevent neural tube defects have decreased folate deficiency to 2 to 10%, from 70 to 75%. Previously, when folic acid was not given as a prophylactic measure for neural tube defects, at that time the deficiency state was as high as 75% of the pregnant females were deficient in folic acid, and that's why when they start lactation, their breast milk is poor source of folic acid. Now from the date, from the time when we have started folic acid supplementation during antenatal period to prevent neural tube defects, the deficiency state have reduced to only 2 to 10% of females having folic acid deficiency. This particular clinical supplementation of folic acid have shifted the significance of megaloblastic anemia in infancy or in children from folic acid, which causes usually megaloblastic anemia in children, to the B12 deficiency, because now the folic acid deficiency megaloblastic anemia is less, or is not that much significant, which B12 deficiency causes. Thus, B12 deficiency as a cause of megaloblastic anemia in children is now uh, having more significance. If we talk about etiology, then the causes of folate deficiency, they are mostly nutritional, and in nutritional goat's milk, the babies who are exclusively fed on goat's milk are usually found deficient in folic acid, because goat's milk does not have folic acid, or mothers who are deficient in folate and do prolonged breastfeeding, they can result in folic acid deficiency in their infants. Other causes are vitamin C deficiency, which is required to preserve intrinsic folate in the body. To preserve folate, vitamin C is required. Further causes may be if we are having a good diet, folic acid rich diet, but there is malabsorption, then there may be folic acid deficiency, like in tropical sprue or gluten enteropathy, that is known as celiac disease, and various intractable or recurrent diarrheas. Some of the drugs which causes folic acid deficiency, they are antimetabolites like methotrexate or sulfonamides, various anticonvulsants. They usually require folic acid supplementation with their prescription. Otherwise, they will result in folic acid deficiency. Or some states, some diseases which increase folic acid utilization, they may also cause deficiency of folic acid, and these diseases include hemolytic anemia and leukemia. That's why in their management folic acid is required. Otherwise, there will be megaloblastic anemia in due to relative folic acid deficiency. As such, folic acid in diet is good, but the requirement have increased. So these two conditions are very important because they need folic acid supplementation throughout the disease course or throughout the drug is being taken. Then there may be some hereditary problems of folate metabolism. So these are some etiological factors wherein diarrhea is intractable diarrhea is a very common cause of folic acid deficiency, or exclusive breastfeeding or prolonged breastfeeding or goat's milk, or drugs. Many children who are epileptic are being given anticonvulsants, and they are not taking folic acid. They will precipitate various features of megaloblastic anemia. Then B12 deficiency, if we talk about B12 deficiency, usually B12 is mainly present in animal source, and breastfed babies of B12 deficient mothers may suffer B12 deficiency. Pure vegetarian or lacto-vegetarian who are not taking animal products, mainly meat or fish, they may suffer B12 deficiency, or congenital absence, which is rare, but if there is congenital absence of intrinsic factor, then there may be B12 deficiency, or juvenile pernicious anemia. We previously talked about pernicious anemia, which is caused by autoantibodies to the intrinsic factor. Then some bomb infestation may also result in B12 deficiency, and surgeries or some anatomical defects which interrupt either the secretion of intrinsic factor from stomach, that is some post-gastric surgeries or gastric resection surgeries, and also defects of ileum from where the B12 is absorbed, they can result in B12 deficiency. And some of the drugs may also cause B12 deficiency, and they are paramino salicylic acid, colchicine, or zidovudine. Pathophysiology, if we talk about pathophysiology, folate deficiency, first and foremost, folate deficiency. Folate, B12, and defects in their metabolism usually results in defective DNA synthesis. How they will produce anemia? They will produce anemia by defective DNA synthesis. The erythroid or erythropoietic system, bone marrow have active cell division. Bone marrow is producing millions of cells every day, and there is high requirement of DNA synthesis daily. And if DNA synthesis is not up to the mark, then this will result in reduced cell production or ineffective erythropoiesis, which will ultimately result in anemia. That is the basic mechanism how the anemia is produced in folic acid or B12 deficiency. In iron deficiency anemia, it is direct that HB contain iron, and if iron is not there, substrate is not there, then there will be no production of HB, and thus there will be anemia. But here in folic acid or B12 deficiency or defect of in their metabolism will result in defective DNA synthesis, which ultimately will impair the cell division by defective DNA synthesis or poor DNA synthesis. Folic acid basically is required for purine and pyrimidine synthesis. Basically, folic acid is converted into its active state, that is methylene tetrahydrofolic acid, which is necessary for various nucleotide synthesis which produce DNA. And if this active state, that is tetrahydrofolate, then there will be poor repair as well as replication of DNA. This B12, vitamin B12 acts as a cofactor for the activation of folic acid. Folic acid is converted into tetrahydrofolic acid or methylene tetrahydrofolic acid, and this methyl group exchange, which makes it active folic acid activation process, this requires B12. That's why B12 deficiency will result ultimately into non-active folic acid and ultimately poor DNA synthesis. And this decreased DNA synthesis will result in pancytopenia. All the cell lines, whether they are erythrocyte or leukocytes or platelets, they all will be produced in less number, and there may be immature nuclei in these cells. Plasma or cytoplasm will mature fast because there will be normal growth of cytoplasm, while nucleus will not mature because DNA synthesis is impaired. In B12 deficiency, B12, if we talk about its physiology, then synthesis of B12 is done by various microorganisms inside the gut, and B12 only is present in foods of animal origin. This B12 is absorbed with the help of intrinsic factor. That is very important. It is a causative factor, or it important factor in pathogenesis of pernicious anemia. This intrinsic factor, which is secreted from the parietal cells in the stomach, combined with the cobalamin, and this complex is absorbed from the ileal receptors, and there is very minimal absorption from rich diet, B12 rich diet. Only 1.5 to 2.5 microgram of B12 is absorbed per single meal, and this absorbed B12 is usually stored as coenzyme throughout the body, but most of the part, that is one third part, is stored in liver, and this storage usually will result in deficiency symptom very late because a good amount of B12 is stored in liver. That's why B12 deficiency will not produce symptoms or anemia for many days. B12 is basically required for the conversion of methyl folate to methylene tetrahydrofolate. That is active form of the folic acid is not made or is not converted, and this will result in poor DNA synthesis. B12 is also acts as coenzyme in other metabolic processes like propionic acid metabolism for the conversion of methyl malonyl coenzyme A and in synthesis of methionine from homocysteine. This will result, this B12 deficiency will result in slowing down of these enzymatic activities or these conversion processes, and there will be excessive accumulation of methyl malonyl coenzyme A as well as homocysteine, which when assessed, their blood level assessed, they are a sensitive marker of B12 deficiency, and they are also a marker of differentiation between folic acid deficiency and B12 deficiency, or raised homocysteine always indicate B12 deficiency. Then clinical features. In clinical features, all the features of anemia, that is e.g. fatigability, irritability, lethargy, loss of appetite, pallor, shortness of breath, they all may be there. In infancy, B12 deficiency usually results in regression of milestones. A baby who have started rollover or sitting or even standing with support, there may be regression in milestone. They may lose the milestone they have earlier achieved, and sometimes there may be infantile tremor syndrome. B12 is required to in various factors, and these metabolic chains may result in various generation of various toxins which may cause tremors or convulsions. That's why B12 estimation is also part of evaluation of this epilepsy diagnosis protocol. Then, in addition to pallor, sometimes there may be yellow complexion in megaloblastic anemia. Hyperpigmentation, we have also talked about it in previous class as well. Usually B12 deficiency or megaloblastic anemia, there is hyperpigmentation of knuckles and nail beds. If there is pernicious anemia like juvenile pernicious anemia, then other features of pernicious anemia like diarrhea, paresthesia, glossitis, or neuropsychiatric symptoms may be present there. And specifically in B12 deficiency, the vibratory sensation of extremities, the limbs, vibratory sensation is affected. These are some clinical features like ball tongue in iron deficiency, as well as glossitis, recurrent glossitis in megaloblastic anemia. This hyperpigmentation of the knuckles and pallor. Diagnosis usually is made on the basis of history, examination, and investigation. Investigation is very much required for the diagnosis. In history, dietary fadism, familial dietary restriction. Most of the North Indians are vegetarian. These restrictions may result in B12 deficiency, or exclusive this goat's milk intake may also cause folate deficiency. Then maternal dietary history is also important if the case is infant. Then history of sprue or malabsorption or bowel resection, Crohn's disease or parasitic infestation to rule out folic acid or B12 deficiency. Drug history, usually sulfa drugs or anticancerous drugs like methotrexate, azathioprine, or anticonvulsants like valproate, they all result in folic acid deficiency. Then there may be familial history for some congenital absence or deficiency of carrier proteins for folic acid, or maybe some metabolic errors which results in B12 deficiency. Examination, usually pallor will be there, recurrent glossitis features of glossitis will be there, hyperpigmentation of knuckles. There may be sometime mild hepatosplenomegaly. Other examination point of examination are to exclude some other condition which may mimic like megaloblastic anemia, like leukemia, so bony tenderness in leukemia or hemolytic anemia. Sometimes there may be bruising in megaloblastic anemia because there is pancytopenia, and this thrombocytopenia may cause bruising or bleeding manifestations. We can summarize all these clinical features like a megaloblastic anemia child will be malnourished, who is fed on breast milk for prolonged period, not only for 6 months, but for 9 months or 1 year. They will usually result in folic acid deficiency. Then there may be mild hepatosplenomegaly. Some of the cases may show bleeding manifestation. The clinical picture may mimic like that of aplastic anemia, because in aplastic anemia there is pancytopenia, or acute leukemia may mimic like megaloblastic anemia. Then tremors due to B12 deficiency. Developmental regression is also an important feature, and hyperpigmentation of knuckle or terminal phalange is also important clinical feature. In differential diagnosis, we already discussed that all the diseases which can produce pancytopenia can be confused with the megaloblastic anemia, like aplastic anemia, leukemia, or myelodysplastic anemia. They usually cause pancytopenia. Then malabsorptive disorders like sprue or celiac disease, they may be sometimes confused with these megaloblastic anemia, and some lymphoproliferative disorders may also have uh, mm, differential diagnosis with megaloblastic anemia. In investigation, peripheral blood smear is very important and may be diagnostic in a particular clinical setup. A low reticulocyte count, uh, according to the level of anemia, corrected rectic count will be low. Peripheral smear will show macrocytes which are having a large ovalocyte. MCV is usually 110, 110 to 130 follicular. Then hypersegmented neutrophils must be there in peripheral blood smear. And hypersegmented neutrophils, what does they mean? They are multi-lobe, more than 5 lobes in the nucleus of neutrophils, and this type of neutrophils should be more than 5% of all the neutrophils. And the RDW, red cell distribution width, is high, that is more than 14. There will be polychromasia, basophilic stippling, Hubble jolly body, they all may be found in peripheral blood smear. And there may be pancytopenia and leukopenia, as well as low platelet count may be there. Bone marrow is diagnostic, and sometime it may be required to do bone marrow, because that is only method to differentiate between aplastic anemia and this type of megaloblastic anemia, where there is severe pancytopenia. In bone marrow, there is megaloblasts, and the myeloid and erythroid ratio is disturbed. In normal individual, it is 3:1, while in megaloblastic anemia, it is 1:1. Erythroid cell lining is more showing more division. This is normal blood picture. This is microcytes with hypochromia. these cells are hypochromic. These cells are having very less peripheral HP. So they are showing hypochromia, and these are cells where there is neutrophils also shown in the picture, that is hypersegmented neutrophils, and macrocytes with vacuoles or oval macrocytes, ovalocytes. This shows megaloblastic picture. Further other investigation in addition to peripheral blood smear, they are estimation of various components like vitamin B12 as well as folic acid. B12 usual range is 200 to 800 picogram per ml, and deficiency state is known as less than 80 picogram per ml. Serum folate normal value is more than 5 to 6 nanogram per ml, but 3 to 5 nanogram per ml is considered as borderline, while if serum folate is less than 3 nanogram per ml, it is considered as a deficiency state. Red cell folate level is more reliable, and it is having range 74 to 640 nanograms. These are non-sensitive, they may be false positive investigations. More sensitive investigations are methylmalonic acid and homocysteine, but they are very costly investigations, and they also differentiate between folic acid and B12 deficiency, because in folic acid deficiency their level is usually normal, and in B12 deficiency their level will be increased. Homocysteine will not be converted to another amino acids due to deficiency of B12. Then if we talk about management, in management the severity should be assessed, severity of anemia should be assessed, and it should be addressed adequately. We have discussed it about in detail in last lecture, that if it is severe enough anemia, that is anemia less than 3 grams per deciliter HP, they may require blood transfusion or packed RBC transfusion, and if a person is having infection, then HB level of less than 4 will require packed cell transfusion. Here, in this megaloblastic anemia, findings of CCF should also be assessed and should be promptly managed by packed RBCs or such treatment. Then main treatment is replacement of BS deficient vitamins, that is folic acid as well as B12 deficiency. Then identification and adequate management of cause is also important. If we are not treating cause, we are only supplementing the vitamins, then it will not produce long lasting results. Improvement of diet is very essential, because both these vitamins are found only from diet, and improved diet or balanced diet or diet rich in folic acid as well as B12 should be also a component of management. Then regular follow-ups to assess the anemia, peripheral smear as well as levels of these vitamins is also done. In replacement therapy, folic acid, the optimum dose is usually 100 to 200 microgram, but as such small doses formulation are not available, and usually we give up to 5 milligram of the folic acid daily even, but even if it is given weekly, it is sufficient. High dose, but high dose folic acid, if we are giving only high dose folic acid in megaloblastic anemia, it will improve hematological features of B12 deficiency as well, but neurological features may get worsen. If there is a concurrent B12 deficiency and we are only supplementing folic acid, then they may worsen the neurological features of B12 deficiency. Folic acid usually produces either GIT features like glossitis, diarrhea, or all these things, or anemia. But B12 usually have neurological features like regression of milestones, convulsions, or paresthesia, peripheral neuritis, and sensation loss, vibratory sensation loss, and all these things. And these features may get worsen if we only are giving high dose of folic acid, not B12. The dose of B12 is 100 to 200 microgram daily, or 1000 microgram can be given weekly for 4 to 8 weeks, and then it is followed by a maintenance dose of 100 microgram daily orally. This large dose can be given orally as well as preferably injectable. Once a week injection of 1000 microgram B12 covalent. uh, Assessment of response, appetite will improve, and there will be sense of well-being within 1 to 2 days of replacement starting of the replacement therapy. Serum iron will fall because it will utilize to produce HB. Bone marrow will totally revert within 2 days to its normal state. There will be no megaloblast present in bone marrow. Patient starts feeling well within 4 or 5 days. Then there will be rectic response within 2 days, and the peak reticulocyte response will be within 4 to 7 days. As we will start rising from 1 to 2 weeks, HB will normalize from 6 weeks to 3 months. And peripheral smear usually become normal after all the macrocytes which were produced previously die to their natural death. That is, they persist throughout their lifetime around 120 days. So 2 to 3 months may be required to peripheral smear to become normal. So peripheral smear may even show macrocytes for 2 to 3 months even after starting the replacement therapy. This is all about megaloblastic anemia. As a Ayurvedic counterpart, again I have missed the slide, but in Ayurvedic counterpart we can say that megaloblastic anemia have features or etiology or the pathophysiology of Vataj Pandu. In Vataj Pandu, the main ecological factor may be the food which increases bath. The mass rus or animal origin products, Anup mass runs, usually is a balsamic quality. If we are not taking this and we are taking only vegetables, sags are all known to increase bath. We are taking only saag work in our diet, then they will result in deficiency of B12, and thus they will increase VAT. And in clinical features, the karshanya of knuckle, the darkening of knuckle is a feature of VAT, tremors, convulsions, paresthesia, various neurological symptoms. They all are produced by the aggravation, aggravation of bath. Thus, we can consider megaloblastic anemia as a Vataj Pandu, and we can treat it like Vataj Pandu by giving Masras or various balsamic drugs. Use of various balsamic drugs will definitely have good results in megaloblastic anemia. This was all about megaloblastic anemia. If you have queries, kindly send on my WhatsApp number. Thank you. Thank you all.